Ladies and gentlemen, welcome back to Chapter 5. Yes, that's right, we're almost at the end. The light is at the end of the tunnel. Oh my God, they'll let me out of this room. Oh, I can finally get out. And so can you. Yes, we're almost done with nephrology. Now we're going to be talking about potassium disorders, because where would we be if we didn't talk about potassium? Yes, potassium, the ion that scares all interns. Potassium, the ion that screws with everybody. Potassium is an ion that to me is near and dear, because my first call as an intern was ruined by potassium, too much of it. My last call as a resident before starting chief residency was ruined by potassium, too low. So it's all coming full circle, ladies and gentlemen. That's beautiful. It's the circle of life. Now, hyperkalemia. Hyperkalemia can be from increased release from muscles and tissue or from the blood. Rhabdomyolysis and hemolysis are both ways you can get hyperkalemia. Increased dietary potassium can also be a problem. What if you ate too many bananas and you had a little bit of renal problem? All those bananas could cause a problem. So, here are some other ways. Deficient or blocked aldosterone. Deficient or blocked aldosterone. If you don't have aldosterone, what are you going to do? Well, aldosterone holds on to sodium and spits out potassium and hydrogen. Hydrogen and potassium have this very strange relationship. Hydrogen is the jealous boyfriend of potassium. And what does it do? Well, potassium says, I'm going out with the girls, and it goes out. And what does hydrogen do? Oh, I'm going with you, I'm going with you, I'm going with you. Hydrogen says, I just want to make sure you're okay. But it's really just a jealous boyfriend. Wherever potassium goes, hydrogen goes with it. But if you don't have aldosterone, what are you going to do? Well, without aldosterone, you're not going to hold on to sodium. Holding on to sodium brings in 3 water molecules with it. And you spit out one potassium and 1 hydrogen. Without the aldosterone, you're not going to get rid of the potassium and the hydrogen, and you're going to get an acidosis and a hyperkalemia. What other ways can you block aldosterone? Well, ACEs and ARBs block aldosterone. Spironolactone and eplerenone are both aldosterone antagonists. And Addison's disease, well, Addison's disease is basically the lack of aldosterone. Now, there are some other causes of hyperkalemia. Metabolic acidosis will cause hyperkalemia, because just like that jealous boyfriend who follows the girl around, the girl always seems to come back. Yes, sometimes you can have potassium that's going to go after the hydrogen. Remember, whenever you have an acidotic state, most specifically DKA, why do the patients present with hyperkalemia? Because potassium and hydrogen have a dysfunctional relationship that should be on Maury Povich. That's right, ladies and gentlemen. If one's messed up, the other one's going to be messed up too. And so states of metabolic acidosis, such as DKA, are also going to have high potassium because of a transcellular shift out of the cells. That means potassium is going to go out of the cells and follow the hydrogen. Yes, they're going to go towards the hydrogen, going towards the light, going towards the hydrogen. Because that's what potassium wants to do. Oh, he's so cute. He was a Abercrombie and Fitch model. I'm going to go after him. That's what they're thinking. And so potassium goes extracellularly towards the hydrogen ions. And remember, the inverse is also true for hypokalemia. Beta blockers. Beta blockers will cause hyperkalemia as well. Beta blockers will cause hyperkalemia as well. And digoxin toxicity. Remember, potassium and digoxin have this sort of strange relationship. Too much potassium displaces digoxin. Too much digoxin displaces potassium. And so if I give you way too much dig, what if you're an elderly patient? You got your pills mixed up. You took too many of them, and now you present with, well, obviously digitoxin toxicity, but also hyperkalemic states as well. And now this is one of those situations. I think I just gave you a case that sounds very board relevant. A patient who's living alone, an elderly, took too much dig. Another one, as I mentioned, was insulin deficiency, such as a state as DKA. This is a very, very common one right here. DKA is one of the most popular ones on the exam. Now, in hyperkalemia, there are some other causes that aren't due to the listed factors I mentioned to you before. Prolonged immobility, seizures, or crush injuries. This is from a muscular release of hydrogen. Muscles shaking, muscles crushed, and muscles not moving releases potassium. Type 4 renal tubular acidosis. Oh, you knew I was going to go there. You knew I was going to mention an RTA. You knew it was going to come about. We all hate RTAs. I know, I was there. But remember, our type 4 RTA is nothing more than decreased aldosterone effect. A decreased aldosterone effect. So it's just like not having enough aldosterone. Same symptoms, same findings. Now, the last one is obviously renal failure. This is basically straightforward. You're not excreting enough potassium, so the values go up. The last one is pseudo-hyperkalemia. If you've ever been an intern, if you've ever been on night float, if you've ever been a resident, even a fellow, any one of us, we've all seen pseudo-hyperkalemia. Beep, 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 beep. Yes. Patient has a potassium of 6.1. Was there hemolysis? Yes, marked hemolysis. Please repeat the lab. This is exactly what happens. We've all been there. In fact, we've gotten so good at it, we even call the lab back and say, hey, by the way, was there even a little bit of it? Please say there was a little bit so I don't have to do anything and I can go back to sleep. No, there wasn't a little bit. Okay, I have to act on it. But pseudo-hyperkalemia is basically an artifact from hemolysis. What ends up happening is you send off your CMP and someone shook it up. Red cells burst and lyse, they release red potassium. Another problem that can be is what happens if the nurse put on the tourniquet, stepped away for a minute because another patient was critical, comes back and draws the blood. The tourniquet crushes those red cells and causes potassium to be leaked in the local area. Potassium levels are high. The only therapy here for pseudo-hyperkalemia, do nothing! Just repeat the lab. You repeat it, numbers come back normal, the patient's going to be fine. Now, here's where we really got to be careful. Remember, peak T waves occur first, then you get a wide QRS complex. When it's true hyperkalemia, you have to know the progression. You have to know that the peak T waves are first, QRS complex widening is second. Now, hyperkalemia will lead to cardiac arrhythmias. Potassium does not cause seizures or neurologic disorders. Why? Because that's a sodium effect. Sodium is used for neurologic processes and depolarization. However, potassium and calcium play a role in cardiac arrhythmias. Now, I'm going to step off the screen. Check out this hyperkalemic arrhythmia. Look at those T waves. Look at that QRS complex. I would call those peaked T waves. Look at V2 and V3. Look at those arrows right there. You got those peak T waves. That is something else. Now, for those of you who've never seen a peak T wave up close and personal, here it is. Peak T wave on EKG. This is a 12-lead EKG. This is V4. Look at how peaked that is. I mean, that thing is up there. It's almost as high as the QRS complex. That's going to be a very dangerous and a very ominous sign. But this occurs first before this QRS complex right over here starts to widen. It's going to occur first. Always remember that. This is another basic science correlate. Remember, on the USMLE Step 3, for those of you who are going to be taking it pretty soon, it might not show up on your exam, but those of you who are studying for a year in advance or going to be starting soon and just taking this course and you see this, or for those of you who are taking the course and it's already 2014 and it's, oh my God, they're basic science correlates. Here it is, a basic science correlate right here. Peak T waves occur first, widening of the QRS complex occurs second. Now let's talk about the treatment of hyperkalemia. The treatment of hyperkalemia is actually based on what you see. In severe hyperkalemia, where there's EKG abnormalities such as peak T waves, what are you going to do? Well, you're going to go ahead and give calcium gluconate. Calcium gluconate IV actually protects the heart. It protects the heart from the effects of the potassium. Therefore, you follow that up with insulin and glucose. Why do you follow it up with insulin and glucose? Well, you want to give insulin to push potassium into the cells, and you want to give glucose to prevent a hypoglycemic episode, because what does insulin also do? It drives glucose into the cells. So calcium gluconate first, protect the heart. Protect the heart, then go ahead and give insulin and IV glucose and get that potassium level down, and you give the glucose to make sure the sugar levels don't fall. Lastly, you can give some K-exalate. Remember, K-exalate is going to take a few hours, and this is going to remove potassium from the body as well, but it's going to take a little bit longer than go ahead and giving calcium, followed by insulin and glucose. Remember, K-exalate is always the wrong answer when you have severe hyperkalemia. It's an adjunct to giving calcium gluconate and following that up with insulin and glucose. In cases of moderate hyperkalemia where there's no EKG changes, you can go ahead and give safely insulin and glucose alone. You don't have to give calcium. You can give bicarbonate. Why do you give bicarbonate? Well, bicarbonate's going to shift potassium into the cell. Why does this happen? Well, remember, when there's acidosis, you're going to have a lot of potassium around. Remember, they go together. And so therefore, when you have an acidotic state, you go ahead and give bicarbonate. It's going to push potassium into the cell. Now, when you have sort of mild hyperkalemia, 5.1, a 4.9. This patient has maybe just had a little bit of bad dieting and they have chronic renal insufficiency. You can go ahead and give safely K-exalate, which is a potassium binding resin. And this is an oral agent to remove potassium from the body. But like I mentioned before, it takes several hours to work. Several hours for this thing to work. Now that's a big problem. Because if you have a problem like this, EKG changes, never use this. Never, 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 never use this when you have EKG changes. Now, hypokalemia has got a lot of causes. You can have increased urinary loss from diuretics. You can have high aldosterone states. Yes, Conn syndrome, the opposite of Addison's. Too much aldosterone means I'm going to hold on to a whole bunch of sodium. I'm going to hold on to all my sodium. I'm going to cause hypernatremia, hypertension, hypokalemia, and metabolic alkalosis. Vomiting. Vomiting leads to metabolic alkalosis. Why? Because alkalosis shifts potassium intracellularly. When you vomit, you lose a lot of hydrogen ions. This makes you alkalotic. When you become alkalotic, again, potassium goes back into the cell. And volume depletion also relatively causes you to increase your aldosterone because of the renin-angiotensin syndrome. So now you have a host of reasons here how vomiting is going to cause you to become hypokalemic. Yes, I'm losing volume from vomiting. And so what happens, the RAT system kicks in, aldosterone goes up, and now I'm holding on to sodium and kicking out potassium so that I don't lose any more volume. Do you see how physiology, do you see how basic science still plays a role in what we do in terms of our management? These three reasons here helps us understand what we're supposed to do for these patients with hypokalemia. Now there's some other causes. Proximal and distal renal tubular acidosis. Yes, I talked about RTAs again. And amphotericin. Yes, amphotericin is a terrible thing. It's amphoterrible. One of the things it can also cause is RTAs. Bartter syndrome. In Bartter syndrome, you have an inability at the loop of Henle to absorb chloride and sodium. If you can't absorb sodium and chloride, you have volume loss. And when you have volume loss, what ends up happening is you have a secondary hyperaldosteronemia. When you have a secondary hyperaldosteronemia from this volume loss, because you can't absorb the sodium and chloride, what do you end up getting? You get renal potassium wasting. Think this through. Bartter syndrome is a beautiful disease in terms of physiology. What ends up happening here is I'm not holding on to sodium and chloride. If I'm not holding on to sodium and chloride or salt, I'm losing salt. And where does water love to go? It loves to go to where the salt is. So the body is now thinking, hey, I'm losing all this water. What the heck's going on? Maybe I'm in the desert. Maybe I haven't gotten enough water. Maybe I drank too many Red Bulls and I peed too much, but I don't know what's going on. But I don't have enough volume. So what does it do? Aldosterone shoots up because of the renin-angiotensin syndrome. Aldosterone goes up. Aldosterone holds on to holds on to sodium, spits out potassium and hydrogen. Now, hypokalemia can have cardiac arrhythmias. Remember, with hyperkalemia, you first have a peak T wave, and then you have a wide QRS complex. With hypokalemia, you're going to have a U wave. Yes, U waves. There it is, right there, and right there, and right there, and right there. For those of you who have never seen it a little up close and personal, we're going to get there in a moment. But muscle weakness. Muscle weakness is another component of hypokalemia because it inhibits contraction. When rhabdomyolysis is severe enough, this occurs. Now let's look at the normal intervals of an EKG. Normal intervals. And I'm going to walk along, and you're going to see the PR, the P, the QRS, the ST, the T wave, and boom, right there, that's the U wave. Do you see how minor it is, how subtle the U wave is? Remember, U waves are present in hypokalemia. For those of you who need to see a little bit more up close and personal, here is a very up close and personal rhythm tracing, and there is the U wave, just right there, hanging out, waiting for the bus. Who's that? You. No, I asked who you are. No, the U wave. I know who you are, but what is it? Well, no, it's the U wave. Now, in hypokalemia, what's the treatment? Replace the potassium. That is right, ladies and gentlemen. For those of you who clicked that answer choice, you're right on the money. But remember, no maximum rate has ever been established on oral potassium replacement. In the hospitals, sometimes we'll say, give 40 milliequivalents, give 80 milliequivalents, because the rule of thumb is about 10 milliequivalents raises you by 0.1. But remember, sometimes you're going to get a little bit of feedback from, say, one of the ancillary members of the staff and say, no, doc, I can't give more than 40 milliequivalents. I can't do it. Remember, no oral maximum has ever been written. However, potassium tastes terrible. Just remember that. Now, the bowel regulates the rate of absorption. So I can give you 100. I can give you 200 milliequivalents. I had an attending once tell me I could give you a pound of apricots because apricots are rich in potassium, and nothing will happen because you have a maximum amount of absorption that you can do at any given time. So there's no maximum rate. Now remember, avoid glucose-containing fluids because they're going to cause insulin release. So if you give this patient D5, their D5 levels are going to cause dextrose, obviously, so they're going to have high sugar levels. High sugar levels are going to cause insulin to go up. And then remember from hyperkalemia, insulin causes potassium to go into cells. And right over here, you're going to worsen the hypokalemia. So remember, be careful with their sugar values. If they're diabetic, keep them tight. If they're going to be needing fluids, try to avoid D5 if you can. Now, IV potassium replacement must be slow so that you don't cause an arrhythmia, and because you can want to consider this. If you give it too quickly, you're going to cause an arrhythmia. And the other thing about IV potassium, it burns. Oh my God. You remember this as an intern, as a resident. You always get that overnight call. Doc, I have a patient who's getting 3 runs of 10 and is saying it's burning. 2 problems with IV potassium that you have to keep in mind. Now let's go ahead and talk about hypermagnesemia. How does hypermagnesemia occur? Well, number 1, we use too many magnesium-containing laxatives, because remember, magnesium causes you to become more likely to contract your bowels. So because you want to get going, you want to stay regular. So you're going to go ahead and use magnesium-containing laxatives. But magnesium-containing laxatives can cause hypermagnesemia, not good. Another thing, iatrogenic administration. Some people just take it too much. Well, yes, we've done this to people too. When? Iatrogenic means by doctors. And when does this happen? Well, as a tocolytic. Remember, premature labor, we use magnesium as a tocolytic. Now, the OBGYNs in the audience are like, no, this is not right. Well, remember, it's a rare finding unless the patient has renal insufficiency. Tocolysis with hypermagnesemia levels only occurs when you have renal insufficiency. Now, high magnesium, what is this going to lead to? Muscle weakness. Why? Because muscles need sodium. And what does magnesium do to sodium? It actually competitively blocks it. They're trying to vie for the same spot. They're going, okay, I got you, boom, boom. And magnesium blocks sodium from depolarizing, so your muscles are weak. And you're going to therefore have loss of D-temptin reflexes because you can't depolarize. How do you treat hypermagnesemia? Pretty straightforward. Restrict the intake. If they're taking too many laxatives, stop the laxatives. If they're taking too many tocolysis, well, you're going to have to talk to the OBs about that. And if they have saline around, go ahead and give them saline. Why? Because if you administer saline, you're going to cause diuresis. And then what ends up happening is they're going to pee out a lot of the magnesium. Restrict the intake, give them fluids. Sounds pretty straightforward, but it is. Lastly, there is an occasional role for dialysis. Yes, some patients are so high in magnesium that they're literally just like this. They're almost near respiratory compromise and you have to dialyze them. Now, hypomagnesemia can be caused by loop diuretics. It can also be caused by alcohol withdrawal. Gentamicin is another call. Cisplatin, making your kidneys go splat. They present with hypocalcemia and cardiac arrhythmias. Yes, too much magnesium is a problem, but too little seems to be far worse. Lastly, magnesium is required for parathyroid hormone release. That's why you get this hypocalcemia. Without the magnesium, you can't release parathyroid. Without parathyroid, you can't regulate your calcium levels. Can't regulate calcium levels, you can't depolarize your cardiac muscle membranes, and therefore you get cardiac arrhythmias. Yes, ladies and gentlemen, that is how hypomagnesia is going to present to you. Ladies and gentlemen, that is the end of Chapter 5. We've discussed potassium and magnesium disorders. The next chapter we're going to talk about, Chapter 6, the last chapter, is acid-base disturbances.